Hello everyone, and welcome to today's webcast hosted by Clinical Directors Network. My name is Sindhu. For today's webcast, we are featuring Dr. Kelly Smith, who will be presenting on the Guide to Improving Patient Safety in Primary Care Settings by Engaging Patients and Families, the Be Prepared to Be Engaged strategy. Kelly Smith, Ph.D., is the Scientific Director of Quality and Safety Research at MedStar Health Research Institute and MedStar Institute for Quality and Safety. Her research focuses on identifying and overcoming lapses in patient safety and improving quality of patient care through innovation and collaboration. Notably, she is a leading investigator in patient partnerships in quality and safety research. Dr. Smith is the principal investigator of the AHRQ Guide to Improving Patient Safety in Primary Care Settings by Engaging Patients and Families. Dr. Smith receives research funding from the Agency for Healthcare Research and Quality, National Institutes of Health, and the Association of American Medical Colleges. At any point during the session, please type any questions for Dr. Smith in the chat box on the bottom right-hand corner of the screen. You may have to click on the purple tab in order to pull out a white panel. Once the white panel opens, click on the chat bubble icon located at the bottom. Questions will be answered at the end of the presentation. In addition, anyone who wishes to obtain CME credits for their attendance should stay on after the Q&A period, and a link will be posted for the assessment in the chat box. Now I'd like to give our time over to our presenter, Dr. Kelly Smith.
Hi, good afternoon, everybody. Thank you, Cindy, for that introduction. It's great to be here today to talk about the Be Prepared to Be Engaged strategy, which is our second strategy that's been released for the Guide to Improving Patient Safety in Primary Care Settings by Engaging Patients and Families. Our work is funded by the Agency for Healthcare Research and Quality through the Action 3 contracting mechanism. And if you wanted to learn anything more about the project, please feel free to give me a call or email me and visit the project website on the AHRQ website. Our objectives today are to review some of the key threats to patient safety in primary care settings and identify some interventions to engage patients and families to improve patient safety. We're also going to describe the role and the value of the Be Prepared to Be Engaged strategy in improving patient safety in the primary care setting and identify some strategies for implementing the Be Prepared to Be Engaged strategy in primary care settings. So to give you a little bit of background, in 2015, the Agency for Healthcare Research and Quality funded a contract through its Action 3 mechanism to develop a guide for improving patient safety in primary care settings by engaging patients and families. The goal of the guide is to create opportunities for meaningful engagement between primary care clinicians and the patients and families that they serve. The goal really is to improve patient safety and promote engagement in ways that improve patient safety and not just quality. The interventions as part of the guide should be based on evidence, should be easy for practices to adopt with minimal technical assistance, and should be geared to practices who have not had much experience with patient and family engagement before. Our project team includes a diverse group of stakeholders, including experts in patient safety, primary care, human factors, patient and family engagement, and healthcare professional behavior change. We work closely with our project leadership at the Agency for Healthcare Research and Quality, as well as our technical expert panel members, to identify scalable interventions to support improvements in patient safety. As part of the contract, we have prepared several project deliverables that are available on the AHRQ website. The first step in the project was to conduct an environmental scan. Here, we conducted a scoping review of the peer-reviewed and the gray literature on the three elements, patient safety, primary care, and patient and family engagement, and looked for opportunities in areas where interventions intersected the three. We also consulted with experts in the domains of patient safety, as well as worked closely with patient and family advisors to identify successful interventions that were potentially available but not always available in the peer-reviewed literature. We worked closely to prepare a series of case studies of exemplar primary care practices from around the country, highlighting their approaches to improving patient safety through engaging patients and families. These case studies are available on the AHRQ project website and cover interventions including open notes, which is an approach that supports patient access to their physician's medical notes to foster communication, team-based care, highlighting approaches to engagement through integrating the patient and family as part of the care team, patient and family advisory committees or councils, which include strategies that have strong histories within the acute care environment and emerging evidence within primary care, and shared decision-making, highlighting how engaging patients and families in decision-making can improve patient safety. From the environmental scan, we identified several threats to patient safety within the primary care setting, as well as interventions that could help close these gaps. The key threats to patient safety included breakdowns in communication, issues in medication management, which included errors in prescribing, filling, and potential adherence on the patient side to medication regimens, emerging evidence indicating breakdowns in diagnosis and treatment, leading to medical error, and things around fragmentation and the environment of care. We also identified an emerging body of evidence around errors associated with opioid prescribing and use, and those were bundled under the medication management. We also identified several promising interventions, which included shared decision-making, patient advisory councils, team-based care, medication management, approaches to engaging families more actively in care, structured communication tools, as well as ways to support patients and families for speaking up and asking questions. This all led to designing and developing a model for patient and family engagement in primary care. This is our very high-level model of meaningful relationship-based engagement. Our approach to guide development focused on reaching our target audiences. Here is in the image represents the three key stakeholders in the primary care relationship within the practice. That includes the patient and family, the healthcare physicians and nurse practitioner or clinicians, as well as the practice staff, here represented potentially by a medical assistant or a member of the extended care team. The triangle here represents the notion of triangulation and demonstrates how interventions can be used to link each of the patient, clinician, and practice staff together in a resilient relationship. The importance of this model is that as part of our guide development approach, we used an approach called co-production, where we engaged clinicians, patients and family members, as well as practice staff in the design, development, review, and revision of these tools, so that we were ensured to be having a paired tools approach. And what that means is that if we had something that was geared towards a patient or family member as the key stakeholder for that intervention, there would also be supplementary tools for clinicians and practice staff to help reinforce the behaviors that we are hoping patients and family members to adopt. The 4 interventions for our project were selected by a team of experts in the field and as well worked with our technical expert panel and our Agency for Healthcare Research and Quality partners with the goal of designing or redesigning existing evidence-based interventions with the goal to reduce complexity, improve usability, enhance opportunity for adoption. Some of those modifications also included ensuring that they were of appropriate literacy level and having a thorough health literacy review. The 4 interventions that are part of the guide include TeachBack, which ensures medical information is explained clearly to patients and families for improved understanding and adherence to next steps. The Be Prepared to Be Engaged strategy, which is encouraging and reinforcing patient preparation for their primary care appointments, as well as engagement with their healthcare team, and encouraging the willingness to speak up and engage actively in their primary care encounter. The medication management strategy, which applies the brown bag approach for medication reconciliation and creating an accurate medication list. And then the 4th intervention is called the warm handoff, which is communication about care occurs at transitions in front of the patient and family and with the patient and family, encouraging them to speak up about any miscommunications or potential errors in the communication that was had. The focus of today's webinar is going to be on the Be Prepared intervention and the tools developed. you might be asking yourself, what is the Be Prepared to Be Engaged strategy? The Be Prepared strategy is an approach that supports patients and their families to become more fully engaged in their medical appointments. During our environmental scan and the relevant literature review, there were literally hundreds of patient-facing strategies available to encourage patient engagement and care. Many of these strategies attempted to integrate several tools like journaling, medication lists, asking questions, and speaking up into a single strategy, which our patients and family advisors found complex, difficult to adopt, and not really useful for day-to-day practice. Working with our patient co-producers, as well as our clinicians and practice staff co-producers, many of the people advise us being overwhelmed with the information being asked of them prior to the appointment. And so our team took a very streamlined approach to reduce the complexity and enhance engagement. When asked about the most important strategies for patients to improve patient safety in primary care, what we heard from our team included elements of shared decision-making and speaking up at the top of the list. The Be Prepared strategy has tools that will help patients to think about the things that are most important to them for each primary care visit and will help patients to speak up for patient safety while they're within the encounter. The goal of the Be Prepared strategy is to help the patient join their healthcare team to be ready for their appointment, to speak up and ask questions, and to take notes. Within the Be Prepared to Be Engaged strategy, there are tools available for clinicians and practice staff, as well as patients, and overall helping to reinforce the engagement within the primary care setting. So you might be asking yourself, why should we use this strategy? Communication here is key. Patients often arrive at a primary care visit unprepared to discuss their current symptoms, medications, or sometimes forget to ask the questions that they had intended to ask due to uncertainty or fear of speaking up. Perhaps they are embarrassed to discuss certain aspects of their care or are simply having difficulty remembering during the brief encounter. Added to this, there are significant time pressures within the primary care encounter that can also impact patient safety. During a recent workshop that we had, our team polled attendees as to the biggest threats in patient safety in primary care. The answer here that we received the highest number of votes on was time. It was quite striking. The Be Prepared to Be Engaged strategy aims to really help patients and families come to the appointment prepared for their visit, thus making the appointments a much more efficient and effective use of the time for both the clinician and the patient. It can also help to improve information exchange and really would encourage the shared meaning, encourages establishing a shared meaning between the patient's family members and clinicians, unlocking the values, preferences, and elements important to the patient and family that can encourage improved patient safety and quality of care. It can also help reveal contextual factors about the patient and their current state of health and well-being beyond what you would normally see in front of you. In a funded AHRQ study published by Dr. Saul Wiener in 2010 in the Annals of Internal Medicine, they reported that physicians who were probed using standardized patients as an encounter, and it found that physicians probed fewer than 51% of the contextual red flags presented to them in a primary care visit. Here, physicians were provided error-free care in only 22% of the contextually complex encounters and only 9% of the encounters that were both biomedically and contextually complex. Preventing patient misunderstanding, poor patient recall, and communication breakdowns that contribute to poor patient outcomes and errors are also a benefit of the Be Prepared strategy. When patients and families are well prepared for their primary care visit, the visit time is used more effectively. Patients and families are better able to communicate their questions and concerns. They're valued as members of the care team and share important information so their clinician can make a timely and accurate diagnosis, and patients and families are more likely to leave a visit with an understanding of their diagnosis and care plan, which should yield improved patient follow-up and execution of the care plan together. When should you be using the Be Prepared to Be Engaged strategy? We're recommending that the Be Prepared to Be Engaged strategy would be most effective if a practice should aim to use the tools with every patient at every visit. By embedding the Be Prepared strategy into the everyday practice workflow, the practices of reinforcing the use of the materials can come from every member of the healthcare team. This should foster further engagement by patients and their families and yield improvements in patient safety, patient satisfaction, and care quality. This slide provides an overview of the available resources as part of the Be Prepared to Be Engaged strategy. There's also a link to the project website available on this slide to make it easy for you to get access to all the materials for the interventions. I'm going to take some time to go through each of the different materials that we've prepared as part of the Be Prepared to Be Engaged strategy. The steps for getting started with Be Prepared are outlined in our Implementation Quick Start Guide. Each one of the interventions that we have has a brief tactical guide for practices to get started. It gives a little bit of background and information about the project. It gives information about why the intervention is important, and also gives you some ideas and tactics on how to integrate it into your practice workflow. When getting started, the first thing you should do is download the Quick Start Guide to help orient you to some of the process-oriented and behavior-oriented changes your practice can do to successfully implement the Be Prepared to Be Engaged strategy. The steps, there's an easy 5-step process as part of each one of our intervention guides and implementation Quick Start Guides. And we're going to go through each one of those today to provide some guidance on how a practice can get started. So step 1, make sure that you identify a champion and get leadership buy-in and support for the practice change effort. This is a key element to all successful practice improvement efforts. During this stage, a practice champion should be identified. The individual will facilitate the practice improvement effort both in the design and development stages. That may include organizing meetings and be the key individual change agent for the effort within the practice. They will probably also lead some of the evaluation efforts as well. You will also want to identify a team that engages representatives from each of the key stakeholder groups within the clinic. And that would include clinicians, practice staff, and practice administrators. Practices may also want to consider inviting patient and family members to engage in the practice effort in a significant way. You might want to start with choosing 1 or 2 patients who are willing to be able to come to your planning meetings. And that may not be every meeting, but having a patient or family advise you on the process of engaging them is a really important piece of the puzzle. This way, you develop a handful of patient practice champions, as well as ensuring the patient voice within the practice change efforts. Step 2 is to really design the implementation. The Quick Start Guide has some great advice on how to get started with each of the patient-facing materials, particularly how to design your processes around the patient no sheet and the patient prep card. Some suggested strategies and step-by-step guidance are provided, and the goal is for this process to be highly adapted to the nature of your practice and the patients that you serve. So this is an example of the patient prep card. It was designed based on the ability to have a patient or family member complete their couple of top questions, what they want to talk about, and what their goals for their health are. It's also structured in a postcard format so that you can use it as an appointment reminder. So some suggestions that we've heard during our field testing of the pilot testing of the materials were that people could use the cards as an appointment card, as an appointment reminder. You can also, if you use a reminder system such as a telephone or telebox or text message approach, make sure you can include a request in the reminder for the appointment that they fill in the card and they bring it with them. It's also suggested that practices keep a supply of blank cards on hand, on hand so that if patients do forget them or that they didn't fill them out, that there's something there to reinforce the behavior of this is an important part of our care. When the patient, again, is brought back to the exam room, there's also another opportunity to check it. I was recently presenting to a practice on the different interventions that were being developed, and one of our colleagues from neurology actually suggested that this would be a great way for their practice to be able to engage patients and families in a meaningful way, and that it may reduce some of the no rates. So there could be other unintended consequences to this particular approach as well. So the goal of the patient note sheet is to help patients and their family members organize the information that is being shared with them at the primary care visit and to serve as a visual reminder of what their next steps are as a patient. It helps to set expectations and reinforce some goal setting together as a team. The goal for the practice would be to keep a supply of the note sheets on hand, to keep a clipboard available, as well as potential writing utensils, as not everybody comes to their appointment with a pen. During the appointment, our goal is to help clinicians offer the patient or family member a note sheet and encourage them to write things down that they want to remember. The clinician can also stress items that he or she would like the patient or family member to follow up on, also just as a record for their test results as well. It's also important to while the note sheets are available and can be offered to patients and families, that it's not a requirement that everybody use them, but that we should have opportunities and processes to encourage their use. The third step is to orient the practice and do some process improvement training around it. It's important to make sure that all the team members are aware of the Be Prepared tools and how the practice has selected to implement them. It's important to engage the team members to understand that the tools and what they are used for so that they can help reinforce their use with patients and families. We have several flyers. We have a flyer for patients, we have a flyer for staff, and we also have a flyer for clinicians. They can be used at team meetings or introduced during a huddle to help ground the conversation by the practice champions about the use of the Be Prepared strategy within the practice and how each individual within the practice can further engage with patients and families using the materials. The fourth step in the process is to orient the patient. The patient fact sheet is available to help your practice inform patients and their family members, as well as their caregivers, about how to use the Be Prepared strategy materials during the primary care visit. This can help practices set expectations for use, convey important information about why it is important to be prepared for their visit, and how it can help to improve patient safety and quality of care that they receive. The Be Prepared strategy can also be introduced and reinforced by every member of the primary care practice team, from the front desk to the primary care clinician. This will help raise awareness of safety challenges and gaps along the care continuum for all members of the team. The fifth step in almost every quality improvement or practice improvement effort is to evaluate, revise, and refine. It's important to evaluate your implementation to determine if changes needed to be made to enhance success. The Quick Start Guide for the Be Prepared strategy provides some strategy-specific guidance on possible metrics that could be used. This could include some direct observations of whether patients or family members are bringing in the prep cards, if the cards are completed, or if they're using the notepads during the appointment. A practice could also include using weekly team debriefs on how the implementation is going from the perspective of each stakeholder within the practice, including patients if possible, and then to identify any barriers to potential use. You could also do something as simple as counting the number of cards returned or the number of times a patient needs a card to fill in while waiting. A simple tally sheet at the front desk can tell you a lot about your processes and what may need to be modified or changed. The goal here is to find out not only if the process is working, but also to ask yourself, why is it working or not? And how is it working? By answering these questions on a regular basis, You're also embedding a systems-based process of evaluation into your daily work. This sets the stage for future implementation successes. So you might be asking, how can the Be Prepared strategy help you? There are several ongoing things in the environment, from the local clinical practice improvement efforts that help to advance care information, yielding improved reimbursement or reduced costs, and then also fully encompassing in the safety and quality. So clinical practice improvement that has strong elements of patient engagement have been demonstrated to improve and expand practice access, improve care coordination and timely communication with patients and families, and increasing beneficiary engagement, such as establishment of care plans for self-management, assessment, training, and shared decision-making. The recent merit-based incentive payment system also measures clinical practice improvement along 8 domains that are supported through patient and family engagement. The full guide will also provide some additional information on other resources that your practice can adopt that will further integrate the elements of the merit-based incentive payment system and other elements into practice. In terms of patient and family engagement with those merit-based incentive payment actions, there are several patient and family engagement metrics that are being assessed through the practice transformation efforts. These include looking at shared decision-making, approaches to health literacy, patient activation, medication management, and support for patient voices. Be Prepared to be Engaged can specifically help with metric 4, which is that the practice can demonstrate that it encourages patients and families to collaborate in goal-setting, decision-making, and self-management, as well as metric 5, the practice has a formal approach of obtaining patient and family feedback. Together, these can all help create a successful opportunity for engaging patients and families in your local practice that will yield greater improvements for the overall practice success. So how do you get started? Identify your champion and a leader for the practice. You want to develop the processes and engaging patients and families using the intervention strategies that we have and the tools available to you. Engage the entire practice as the team, get everyone's input, and then forge forward and do rapid cycle improvements. Inform patients and families of the practice improvement efforts that you're undertaking. It's amazing how much they want to engage in this, and evaluate and refine the process. Those are your steps to success. So I'll now open the floor for questions.
Okay, great. Thank you for that great presentation. And now we'll transition to our Q&A portion of today's event. So we'll start off with a question by Ray. Have clinical partners and collaborators discussed workflow issues regarding appointment time? This is valuable but could significantly lengthen appointments.
It's a great question. I think that time is is top of mind for every one of the primary care collaborators that we had, particularly with respect to this practice improvement. What we've been hearing from our clinical partners is that while this may appear at first to lengthen an appointment, it actually provides a little bit greater structure for the appointment. It makes sure that we're meeting both the needs of the patient as well as the needs of the clinician, and it will allow for better information transfer. One of the use cases brought up by a geriatric practice that we worked with was having their patients go home with the understanding that keep this on your fridge, keep the prep card on your fridge. If you get to 3 questions, or if there are 3 things on your card that you need to talk to me about, that indicates your need to come in between our regularly scheduled appointments. It means you need to come into the practice and to follow up on these. So it helps to provide a little bit more structure and guidance as well to that engagement.
Okay, thank you. And now we have a comment from Nikki. She said, "This is great. I just suggested a patient do this the other day, and it seemed to really help her."
That's great and very exciting. And these tools are already available on the Agency for Healthcare Research and Quality website. You can follow the link in the presentation, as well as, if you Google Patient and Family Engagement Guide in Primary Care, that's the first item that will come up. But that's great reinforcement, just this being an important component of engagement for patients and families.
Okay, thank you. Next, we have a question from Gina. Did you test successive distribution of resources via EHR portal?
It's a great question, Gina. We actually have not tested the effectiveness of distribution through an electronic health portal or a personal health record, partially due to needing this to be a very low technical assistance approach and something that every patient is available for. So I don't see any issues around integrating this approach or this question approach into that process, but it would take a little bit more resources than I think that we had as part of the project. But you could certainly take the intent of the Be Prepared prep card and translate that into an electronic vehicle.
Okay, and Jen asks, how are you tracking referrals to resources supporting social and economic determinants of health indicators other than primary care?
It's a great question, Jen. As part of this particular project, the goal is really to design and develop the materials and to disseminate them to practices. Our major metric is less about the effectiveness of the tools in practice and more about whether or not practices are adopting them. And really we're looking at high-level feasibility of adoption and usability of the actual tools, and less so about their impact on the social and economic determinants of health. But I think that those are great metrics that a practice could individually consider as part of their evaluation portfolio, and we would love to work with that practice on potentially doing an impact case study on that data. Lots and lots of research to be had, and particularly around health disparities and social determinants for primary care, for sure.
Great. Next, Louise asks, do you have recommendations regarding which members of the staff should discuss this information with the patients? For example, should patients share their information cards and questions with MAs and PCTs or wait until the physician comes in?
I think that's a great question. Oftentimes in the primary care practice flow, you'll need to make that determination practice specific. Many of the smaller practices may not have MAs or patient care technicians, but many of the larger practices do. And from a flow perspective, we would recommend that the medical assistant describe and discuss the information on the card first with the patient and make sure that that's in the, as part of their process, translate that into the medical record. As part of the overarching guide, we do have 4 total interventions, and potentially that card could be used as part of the warm handoff intervention, which is our 4th intervention to be used. And that information can be shared verbally with the patients, in front of the patient and family member with the clinician during a report out in a warm handoff scenario.
Okay, thank you. Mickey asks, patient safety, particularly the prevention of error, can be difficult to measure. Can you please provide examples of how safety is being evaluated within the project?
Great. That's a great question, and I think something that is extremely challenging to measure in a primary care environment. As part of this particular project, our goal is really our field test, which is the next phase of the project, is to examine and evaluate the feasibility of implementation and the usability of the tools primarily. We're not really looking at effectiveness because as an individual intervention, each one of these interventions has already been established to be effective from an improvement in patient safety or closing the gap in one of the safety threats like communication. So this particular project isn't going to be looking at that. The guide, however, does provide some tools and techniques for evaluating patient safety in primary care. Some of those can include the AHRQ Medical Office Survey on Patient Safety Culture. There is another approach that has just recently been developed out of England, looking at patients' perspective of patient safety in the primary care space. And so those links to those tools and those resources are available as part of the overarching guide.
Okay, thank you. Jeff says, hi Kelly, thank you for this presentation. Which human factors methodologies were utilized in developing this model?
It's a great question. And I wish I had my human factors person on. She's on the list, but not here as part of that. I particularly like the socio-technical systems model for evaluating materials. So we grounded it in socio-technical systems approach for developing and for examining each intervention.
And our next question is from Louise again. Ultimately, is the objective to have primary care practices implement all 4 interventions into their workflow, or pick 1 or 2 that they feel would best help?
That's a great question, Louise. Ideally, a practice would serially implement the 4 interventions. You would get, I guess, if you want to gain the biggest bang for your buck, you would implement all 4. But a practice can see improvements with implementation of just 1. So, and in terms of trajectory, we're presenting them or in the trajectory of both ease of adoption as well as strength of evidence. So teach back would be the first. The second would be prepared to be engaged. The third would optimally be medication management. And then the fourth would be warm handoff in terms of trajectory.
Okay, great. And Michelle asks, will you please repost the link to the resources and guide?
Okay. Yes, absolutely. We can do that at the end of the presentation.
Great. Okay, so Jeff has another comment. He says, thanks for your reply to my question above, Kelly. We are applying cognitive systems engineering methods in our work in Maine, a human factors research method focused on socio-technical systems. I would love to connect with your HF person. Would you consider having them email me? Okay, and his email address is listed. I can also send that to you, Kelly, if you'd like.
That's fantastic. Yes, absolutely. We are definitely looking to collaborate. We have a team of human factor scientists out of our National Center for Human Factors in Healthcare that would be great to connect you with as well. And I'll just ping Kelly Baker to grab the email and we can set something up. Excellent. Thank you.
Okay, great. Thank you so much for all of your questions to our participants. And thank you, Dr. Smith, for a really wonderful presentation and for answering all of our questions. So that's all the time that we have for today. And as a reminder, the recording of this presentation will be posted to our website, www.cdnetwork.org. And for those wishing to obtain CME credits for their attendance, please look to the chat box where we'll post the link to the evaluation. So thank you again, Dr. Smith, and thank you everyone for joining us today. And we'll also be sure to post the link to the resources and the guide into the chat box as well. Thank you.
Thank you, everybody.